So, if your kidneys fail, how do you stay alive? Well, for millions of people, the answer is dialysis, this amazing process that cleans your blood. But to do that, you need a really reliable, long-term way to get to the bloodstream, multiple times a week. So today, we're going to dive into the incredible biological engineering behind the best solution we've got, the arteriovenous fistula.
To really get the scale of this, we have to start with this number. 37 million. That's the estimated number of adults just in the United States living with chronic kidney disease. I mean, that's more than 1 in 7 adults. It's huge.
And this isn't just a US issue, not by a long shot. It's a global crisis, and the stakes are literally life and death. You see this here. For so many people around the world, treatment just isn't affordable, and that leads to over 1 million deaths every single year from untreated kidney failure. This is exactly why getting reliable, long-lasting access to treatment is so absolutely critical.
Okay, so let's start by digging into why this is such a massive global health challenge.
The numbers here are just staggering. Chronic kidney disease affects 10% of the entire world's population. Here in the US, you've got almost 786,000 people with end-stage renal disease, and the vast majority of them, we're talking 71%, are on dialysis. This treatment is so intensive that it eats up almost 7% of the entire Medicare budget. And beyond the money, CKD just dramatically jacks up your risk for heart disease, stroke, and an earlier death.
So, to put it simply, when your kidneys just can't filter out all the waste from your blood anymore, dialysis has to take over. It becomes this crucial mechanical lifeline, doing the job your organs can no longer do.
But providing that mechanical lifeline creates this huge medical and engineering problem. Let's call it the dialysis dilemma.
And here's the central question, right? How in the world do you create a durable, safe access point into a person's bloodstream that can handle being stuck with large needles 3 times a week, maybe for years and years?
Well, option number 1, and the best one, is the arteriovenous fistula, or AVF for short. This is where a surgeon goes in and directly connects a patient's own artery to one of their veins, usually right there in the arm.
The second option is an arteriovenous graft, or AVG. Now, in this case, a synthetic tube is used to bridge the gap between an artery and a vein. You can just think of it as an artificial blood vessel.
And then there's the third option, which is often used when you need access, like right now. It's a central venous catheter. This is a tube that's inserted into a big vein in the neck or chest, with the tip of it sitting right near the heart.
What's so great about this slide is how clearly it lays out the pros and cons. The catheter? Yeah, you can use it immediately, but it has the highest risk of infection by far. The graft is ready sooner than a fistula, but it's really prone to clotting. But the AV fistula? That's the one with the lowest rates of infection and clotting, which makes it the best long-term option. The main drawback? It takes a while to be ready, and sometimes it just fails to develop. But even with that risk, it's considered the gold standard.
And that is exactly why there's such a strong push in medicine for what's known as the fistula-first approach.
This image just perfectly illustrates the basic idea. It's so clever. Surgeons take a high-pressure artery, you see it there in red, and hook it up directly to a low-pressure vein in blue. And this one simple connection kicks off this incredible biological transformation. Think of it like you're building a biological superhighway. By rerouting all that high-pressure blood from the artery into the vein, you force the vein to adapt. It responds to this new stress by getting thicker, stronger, and bigger, basically transforming itself from a quiet little country road into a robust, durable superhighway that can handle the heavy traffic of dialysis. And the payoff for doing this? It's huge. Patients who use a fistula for dialysis have a 20% lower mortality rate compared to patients who use a graft. It's a lifesaver, literally.
But there's always a catch, right? The superhighway isn't open for business on day 1. It has to mature. And for that, doctors use a handy little guide called the Rules of 6.
These are basically the key benchmarks a fistula has to hit before it's ready to go. So, after at least 6 weeks, the vein needs to be at least 6 millimeters wide, less than 0.6 centimeters under the skin, have a blood flow of at least 600 milliliters per minute, and have a straight section of at least 6 centimeters for the needles. It's a really simple but super effective checklist.
And right here, you can see exactly what that means in practice. On the left, that's an immature fistula. Just look at that low blood flow, only 215 milliliters per minute. Nope, not ready. But on the right, that's a mature one. You can see that powerful flow of 877 milliliters per minute. That one is ready to be a lifeline. The difference in the ultrasound is just night and day.
But even with this remarkable biological design, you can still run into trouble on the superhighway.
This is the single biggest hurdle. Failure to mature is the most common problem. And for fistulas that are created down at the wrist, the failure rate can be as high as 70%. I mean, that's a staggering number.
So what's the most common culprit? It's a word called stenosis. In simple terms, it's just a narrowing or a blockage in the blood vessel. It's like a major traffic jam on that superhighway, choking off the flow and stopping the fistula from developing or working the way it's supposed to.
This diagram shows us a really common trouble spot. That little area right after the surgical connection, doctors call it the Juxta-anastomotic region. That's a frequent spot for these narrowings to pop up in a wrist fistula.
And this is what it looks like for real. On the left, the grayscale ultrasound shows you the physical problem. You can literally see the vessel walls pinching inward. But the image on the right is even more dramatic. The color Doppler shows the effect of that narrowing. You get this chaotic, high-speed jet of turbulent blood. It's an unmistakable sign of a serious blockage.
Which brings us to the most crucial, final question. The arteriovenous fistula is an absolutely amazing piece of biological engineering. It's the best lifeline we have for dialysis patients. But, given all these challenges with getting it to maturing and preventing failure, how can we get better at predicting, preventing, and treating these problems to make sure every single patient's lifeline is strong enough for the long journey ahead?